I'd like to welcome you all to this special presentation. I'm going to turn it right over to our guests. Start with Jeff Wells to introduce himself.
Hi, I'm Jeff. I'm a patient, and I've been involved in medical research ever since the patients program brought me along.
Julie, you can go ahead and introduce.
Good afternoon, everyone. I'm Dr. Julie Doherty. I'm the Assistant Vice President for Research Compliance here at the University of Maryland, Baltimore, responsible for the Human Research Protection Program and animal oversight.
Sure. I'm Mary Ann Williams. I'm a librarian here on this campus at the Health Sciences and Human Services Library. My interest in health literacy stems not just from librarians wanting to connect users to quality information, but also from my personal experiences as a patient, a parent, and a caregiver. So here at the library, I teach 2 health literacy related workshops. I oversee the content of a health literacy subject guide, and I've been a member of an interprofessional intercampus faculty group that works on various health literacy initiatives.
So we're going to have just a kind of a short presentation from each one of our panelists, just to tell them a little more about their background and let you know that when we have our mini conference format, that this is kind of the things that are important to them, the things they can share. So Jeff, I will bring up your.
One of the first questions I dealt with when I got involved was, do I really belong here? There were so many things to learn and so many things that were a part of it. And I was wondering, my medical journey is in Baltimore, which is an incredible medical town. And I have been very blessed to be able to get great medical treatment. Before I got sick, I had an opportunity to go to the Holocaust Museum in Washington, D.C. And it really startled me how people were able to participate in things that were just horrific. But after my medical challenge, I had to find things to keep me occupied. I was no longer working. And I found the University of Maryland's mini med school. And one of the courses that I took was the year that the book Henrietta Lacks came out. And it gave me an opportunity to learn a little bit about research and think about what it did to people in Baltimore and what the effects of it were. Part of my rehab, I was a participant in stroke rehabilitation studies at University of Maryland and Hopkins, VA, even Towson University. Because I'd had an unusual stroke, they asked me to be part of a trial patient for students. And it allowed me to learn more about my stroke and about what I could expect by hearing it explained by different professors and different doctors. I was invited to the patients program when they hosted a meeting with the PrEP study. I gave my opinion and thought that was it. Then the study contacted me and asked if I wanted to continue. I was helping with other patient partners, and we met researchers and doctors and surgeons that really were enthusiastic about helping us understand and to explain things to us in a way that made sense. And the way I described it is, it was a peek behind the curtain. I took a course on medical research. One of my local university has an adult education program, and the teacher there described IRBs and the role of ethical research. I was then asked to be a patient representative on a data safety monitoring board for another research study. This gave me a much greater appreciation for the health protections for people doing research. Then the patients program kind of linked me to the Health Research Protections Office at University of Maryland. And I was asked if I would be interested in being a non-scientist. And I went through the training, and it gave me an understanding of what was going on, but I didn't feel like I had full knowledge. What became apparent after the first meeting was that I did not need to know what they were saying. They needed to explain it to me in a way that I understood. So I felt like I had a seat at the table, that it made difference. I wasn't at the little kids' table at Thanksgiving. The amount of information that we see about human subjects research is incredible. I learn something with every review that I do. However, one of the things that really helps me is the monthly research seminar that the School of Nursing does. And that's given me an opportunity to take a deep dive into individual subjects. And then I can go back and rewatch those. We'll share these links, but that idea of there being things that can be explained has really helped me. I learned something from every review that I do. And one of the best ones was that I learned that the city of Timbuktu is in the country of Mali. And that allowed my trivia team to win one night at trivia. And that was important to them. So here I am. I didn't know if I belonged, but I do belong here.
Following Jeff, I'm going to touch on IRBs, consent forms. One of the things that I think is extremely important when we're talking about informed consent and health literacy is, yes, we have informed consent documents. And all of us here, many of us have human subjects research experience, and we know that consent documents can be extremely complex, can be written at a very high grade level, and we have to tailor those consent documents to fit the individual studies. One of the things that is extremely helpful in this process is to have a template, whether it's an institutional template that has all the elements of consent disclosure. When you are looking at creating a document, there are elements of consent that are federally mandated, which make up the elements and the content of the informed consent document. And having a template is extremely important because it can help facilitate that review of the document and make sure that no elements of consent disclosure are missed. I highly recommend using a worksheet or a checklist along with that to make sure that you have included all of the elements. Our IRB uses a worksheet to make sure that all the information is included in the informed consent document. In addition to, federally mandated elements, then there are different agencies that also have additional requirements for informed consent, such as, the Department of Defense, the VA, etc. One of the things to consider these days is the use of electronic consent. And there are requirements there to make sure that the information is presented in a format that, is understandable to the research participants and can be disseminated in a manner that appropriate electronic consent and signatures can be captured on the informed consent document via the electronic method. For the IRB review process, the Institutional Review Board will look at the informed consent document. They have the capabilities, and the PI has the options to request, waivers of written documentation of informed consent, or an alteration or waivers of the informed consent process. These are all aspects that can be requested at the time of IRB submission, and the IRB can make that determination as to whether or not an informed consent, written informed consent is required. One extremely important thing is that goes along in tandem with the informed consent document is the informed consent process. So we like to say it's not just about the document. Try as much as we can, both the investigators and the IRB, some of the wording in these consent documents still raise the reading level pretty high. Some of the names of the drugs, some of the names of the procedures, you just can't, change that type of wording. So sometimes the reading level is high. So coupled with the informed consent document, it is very important that you outline an informed consent process that can go hand in hand with the document. So what do I mean by that? So the IRB is going to ask for a description of the consent process. And that will include who's going to obtain informed consent. Is it going to be the principal investigator? Is it going to be the lead study coordinator? Is it going to be both individuals? If consent is going to be obtained from a legally authorized representative, there needs to be a description how the study team will confirm that that individual is the legally authorized representative, and can they provide legally effective informed consent. The consent process also needs to describe the settings for consent. Is it going to be in a private room, in an area where there's not noise or distractions, and allows for the participant, their family members, and the study team members to focus on reviewing the document and answering questions that individuals may have. There also needs to be a description of the provisions for assessing participant understanding. How does the PI know that the participant or the LAR understands the content of the informed consent document? Is a document or a process such as the mini mental status exam being used to assess comprehension? And then there also needs to be a description of the considerations for ongoing consent, because as we are all aware, consent is just not a one-time event. Consent needs to be ongoing. It needs to be a process that continues throughout the individual's length of participation in the study. There needs to be an understanding that if new information comes to light that may affect an individual's willingness to participate, that the PI has an obligation to inform the subjects in a timely manner. So this has to be thought out at the beginning of a study, so you can plan for those types of activities during the course of a study. Standard operating procedures at an institutional level will outline an informed consent process, but we highly recommend study-specific SOPs related to informed consent processes. There may be sponsor SOPs, institute SOPs. Again, studies differ in their complexity and the type of recruitment processes. So it's very important to understand what both your institution requires in terms of the informed consent process and what your study-specific processes should be. In terms of vulnerable populations, you have to take into consideration if you are going to enroll anyone who is cognitively impaired, children, prisoners, those who are economically or educationally disadvantaged, pregnant women, employees, students, or wards of the state. All of these types of vulnerable populations would require different components in the descriptions of their informed consent process. For example, for children, you would have to have a process for obtaining assent and or parental permission. So that would need to be part of the institutional SOPs that you are aware of and you will follow, and any study-specific SOP you might develop. In terms of obtaining informed consent.
Julie, I wanted to just wanted to break in here for just 1 second. I wanted to make sure that we had enough time for everyone to do their introductions. I didn't know if you were about wrapping up.
Yep.
About 5 minutes, so.
Yep, the other piece is having a delegation of authority log and making sure that individuals are allowed and have been trained to obtain informed consent from research participants. And here is where you would find information about whether at University of Maryland, Baltimore, or at any type of institution about training and education on informed consent documents and informed consent processes.
So you already know a little bit about me, but one of the things I'd like to say is that I know many of you attending today are involved in healthcare on a professional level, but I would like for you to keep in mind that each of us is a consumer of health information and may experience low health literacy at any point, be it as a patient or be it as a caregiver. So what we discussed today in terms of health literacy will be applicable both to your professional and your personal life experiences. So while we're in the large group, I'd like to mention a few points. And Joe, if you could change the slide, please. So there are a lot of different definitions of health literacy. They're all basically the same, but the one that I like to share is the revised healthy literacy definition in Healthy People 2030. So most health literacy definitions always revolved around the person. The emphasis, the responsibility was on the patient. And in this particular definition, personal health literacy is defined as the degree to which a person can find, to understand, and to use not just information, but also services to inform health-related decisions and their actions for themselves and others. So now caregivers are included. Now you are probably aware, but if not, that patients have always had the right to request information in a format that you can understand. Most hospitals and doctors' offices have a patient bill of rights, which includes the right to have information presented in a clear manner and in alternative formats and languages. But now, the nice thing about the Healthy People 2030 is that they now have this part 2, which brings more emphasis to the role that organizations have. What is their responsibility in providing information that can be easily understood? And it's also interesting to note that they also now include organizations need to equitably enable individuals. And we know there are a lot of inequities in healthcare, a lot of disparities. COVID certainly brought a lot of that to the fore. So it's really nice to have both the part 1 and part 2 as part of the Healthy People 2030 definition. So we're talking about health literacy. There's different terms and tools that often come up, and I just wanted to, in the large group, go over 3. Oftentimes you hear people refer to clear health communication. And the definition is easy: health information written or presented clearly in a simple, easy to read format. Sometimes people also use interchangeably the phrase plain language, which technically is defined as communication that your audience can understand the first time that they read it. It doesn't have to be repeated over and over again. For healthcare providers, there are actually some glossaries that can help you explain a concept in easier to understand language. From the consumer perspective, there are also tools to better help you understand medical jargon and also to evaluate health information and to avoid misinformation. Now, one of the techniques that is often used and might be used, Julie kind of referenced finding out whether someone understands what was being said. One technique that is often used is one called teach back. It's used by healthcare providers to ensure that they have explained the information clearly. They're not asking the patient to repeat it to make sure the patient hasn't forgotten anything, although that might be part of it, but really it's not a test of the patient. It's really to reflect whether they have correctly and carefully communicated that information and the patient was able to absorb it. If you're in a situation where your provider does not, or you're in a research process and you're not understanding something, or it was explained and you're still not sure, you can actually use this technique. You can say, you've told me a lot of information. Let me make sure I understand what you're telling me. I need to do X, Y, Z, or you were saying this, that, or the other. So again, you can be using that same technique even if your provider is not. There are many benefits of incorporating health literacy into patient-centered care and into research. I think one of the main things is that it builds trust in the research process, in science, in healthcare providers, and in the healthcare system. So being able to understand written or verbal information really helps to create an atmosphere of trust. Using words, big words, medical jargon really does the opposite. Trust in healthcare research and providers and healthcare systems is actually at a very low level, especially in certain populations. There was a 2014 article which reports that trust is down to 43% from 75% in 1966. And certainly COVID has brought a lot of the trust issues to light. And here in Baltimore, actually, as Jeff mentioned, many people remember Henrietta Lacks and the controversy around using her cells. So just to mine down a little bit deeper, using these health literacy techniques helps to increase the understanding of the research goal and its value. Its value to science, its value to the person, or its value to the family member or future family members of a person. If there's a disease like sickle cell, that's, for example, that's being looked at. It also helps with recruitment. If people can understand what you're trying to get at, why this is important and what it's all about, they may be more likely to volunteer. It also can help with increasing compliance, making sure that if they are involved in a trial, that they will be following the instructions correctly because they understand what those instructions are. And it also aids in retention, because if I'm really involved in it, if I'm really engaged because I understand and I'm now trusting, I will stay through the duration of the process. And sometimes we know those processes, these trials can go on for a while. As Julie mentioned, informed consent forms are a big issue in terms of being clear, but there are some ways that you can help demystify by using some techniques and maybe adding some more common wording into the informed consent forms. And last thing I'll just mention is that it really can help in promoting understanding of things like probability and risk. Numbers, numeracy as it's called more formally, is not something that many people feel totally comfortable with. So I might not understand what 84.5% of the population is. That really means nothing to me, but there are ways that you can make that more meaningful. So with that, I'm going to close.
Jeff, you're going to say something?
One of the things I was going to say is that I have observed in myself that I'm more comfortable in the medical world. Part of it is by learning more and knowing more things, but also by seeing the humanity that sometimes gets lost behind the white coat, by seeing the people and by them seeing me as a person, and I don't feel like an object. So I won't say I'm comfortable in the hospital, but at least I know that there are people behind, you know, the white coat that's scary. And that's what I can share with other patients that are beginning their journey.
Curious how you get them to see you as a person.
A very simple technique that comes from my previous world is looking people in the eye and keep looking until they look back and see you. A lot of people tend to look at the chin or the chest and not make eye contact, especially if they're reading a computer screen or they're reading a document. Then they will glance at you, but they won't make eye contact. And I almost force it because I very much believe, and I tell nurses, even if the patient is in a coma, and I was in a coma And I have some recollections from them, some of which my wife doesn't agree with. Like I remember the night they left me on the rooftop with the helicopter landing. And then I remember the night they left me on the dirt floor in the basement of university. And she says there isn't a dirt floor, but I was there, I know it. But I also remember that I went to Kansas to see my Uncle Harvey and Aunt Lou. Years later, my cousin from Kansas sent me a photo album, and I called her and she said, Jeff, you don't know this, but when you were in the coma, I called and a nurse held the phone up to your ear and I could talk to you for a minute. And I'm tearing up right now thinking about it. But looking people in the eye, even the unconscious patient, I don't care what's beeping and on fire, look at the patient, tell them, hi, I'm hearing this, I'm going to take care of it. But that continuing that eye contact during visits and during interactions. And then they see you as a person, not just the diagnosis.
Jeff, so you joined the IRB. What were some of the steps, or what was the process to kind of prepare you to join that
They sent me,
that
signed
kind
me
of
up for
position?
lots of training, but I also had participated in studies. So kind of my cheat was to go back and look at all the consent documents that I had signed and not really read. So I actually knew a little bit of what I was supposed to know. I went through the training, and it's very similar to things that you can find on YouTube, the links that we'll provide. But it was to explain it in short bites, what the different parts were. Instead of trying to digest all of it at one time, it was to learn a little bit about the history of research and why there are guidelines, and then how those guidelines were developed. One of the neat things for me was we talk about the Belmont report, and that's where the federal law was developed and the requirements for health research after some horrible things were done. The Belmont Manor is in Elkridge. It's not, it's 10 miles from University of Maryland. I thought it was in New York. Belmont Stakes, that's what I always thought, but it's in Howard County. That was just kind of neat. Those little details add maybe flavor and make things more interesting to me. So learning that, and so now when I go to IRB Zooms, I always have the Belmont as my background. It's just my little thing to make me happy. Curiously enough, a couple of the doctors that help treat me and that know me are on the IRB. And my neurologist once made a present, or once told the board, you have no idea how far Jeff's come, because he met me in the coma. He met me before I remember meeting him. So I find it personally rewarding. I find a lot of value in what I do.
So Jeff, if someone, you said you go to support groups, you see yourself as a patient advocate. If someone wanted to get into that kind of realm, if you will, what are some steps that you would advise? Like, if you want to be a patient advocate, what would you do?
Whether it's with the IRB or anything else, almost all hospitals that do research, or all places that do research, have IRBs, and they are welcoming non-scientists, people that can be the voice and can look at things and can help. It used to be, oh, we got to do it. Now it's, oh, we need to do it. And I have felt a change in the direction of interest in having non-scientists involved. Anywhere that has an IRB that does research, the research has to be approved by IRBs. So contacting them and saying, I'm interested in what you do and how you do it. Almost all non-scientists are the smallest part of an IRB. At University of Maryland, just a few months ago, there were only 4 non-scientists that had to go to cover 8 to 12 meetings a month. usually with a review. So non-scientists are very welcome. And the learning process, well, some of it is dictated, there are requirements for what learning you have to go through, and then sit through a few meetings to see the process. A lot of it is available on YouTube and the Health and Human Services links that we provide have the same kind of training, the same information.
Great. A question in the chat. Who do you work with when it comes to potential clinical trial patients?
As part of the IRB, I don't interact with patients as a member of the IRB. I'm reviewing the documents from the researchers. With trials that I help with or that I'm associated with, it's those that have enrolled, and generally I wait until they complete treatment. If they're in the follow-up phase, I will be in contact with them. That way I don't interfere with what the process of research is. But to support the follow-up, how are you doing? We've quit calling it follow-ups, it's check-ins. And we don't refer to people as subjects or participants even. We just say somebody who has helped us, because all of a sudden it goes from an us-them kind of idea to an inclusive. We have learned what you've given us from what you've given us. And that's a whole different way of thinking. And I can spread that to the researchers.
Yeah, I think it's an important distinction that you are in a number of roles, that you serve on the IRB, which looks at research protocols before it goes out to clinical trials or to whoever it might be. But you also advise on research, you advise the patient's program, but you also work as a patient advocate in different, kind of like you said, support groups. So you're kind of looking at it from two different perspectives that need to remain separate, but are.
I kind of silo my interactions so they don't cause an effect.
Mhm.
I don't know if that makes sense, but to me it does. So
Yeah,
so you got to go with it.
absolutely. So how did you find out about the opportunities for the IRB and
A
advocacy?
lot of the initial studies that I was in came from the support groups that I went to. They said, oh, there's this study being done, there's that study being done. And one of the support groups was the Trauma Survivors Network. Shock Trauma has an active trauma survivors group. And the nurse that coordinated that heard about doctors that were interested in doing a study. And that brought a group of us to the conversation. It was a PCORI funded study, and they wanted to talk to patients. But the most impressive thing was they listened. They wanted to hear. They changed what their question was, how they phrased it. And then they said, hey, do you want to keep helping us? And several of us have kept helping them. And that meeting, I didn't know at the time, was hosted at the patients program. And by the patients program, I just heard names that I didn't remember. And the patients program said, hey, Jeff, can you keep talking to us? And they set Eric out to shoot some video of me walking on the treadmill. And it just has blossomed into this incredible friendship.
Absolutely. Remember, if you have any questions or anything you'd like to add to the conversation or ask Jeff, definitely you can raise your hand or put it in the chat. So Jeff, you've been on the advisory board for our Patients Professors Academy. Some people on this call are familiar with that, certainly, and some may not be as familiar. What was that role like in advising, kind of a bigger initiative with?
In my mind,
patients?
I've always thought there are two kinds of people in the world. There are those that say, this happened to me, I want to make sure it happens to everybody else. And there are those that say, this happened to me. I want to make sure it doesn't happen to anybody else. And I am both of those kinds of people. I have had great things happen to me and I want to share with everybody else. And I have had things that I don't want anybody else to have to deal with. If I could wave a magic wand and nobody ever has a stroke tomorrow, I would do that. But that's not going to happen. Probably not going to happen. But I have had the benefit of research. And the benefit of the research was not that I learned how to walk better, I keep my balance better. It was that I was around other people that didn't quit, that didn't give up, that made the best of what they have. I was around that spirit, and they built that in me. They let me see that, and the power of other patients learning how to smile. One of the most powerful messages was one day a group of us had been in a study and we were all waiting for our pickups, and a person who was very new to it was talking to a person who had a paralytic arm and it doesn't move. And she said, well, keep working with it. It'll get better. And he said, no, it's not, but that's okay. And it's that survivor and thriver mentality of make the best of life where I am.
Another question. So have you dealt with physicians or researchers who you feel don't treat you as an equal in a study or in a research capacity? And how did you deal with that?
I've had kind of an unusual ability in that I don't necessarily, I have the opportunity to not describe everything that I'm involved in. And I remember one time there was a doctor who was kind of poo-pooing something. And then another doctor came in and said, hey, Jeff, I saw you at the IRB the other day. I forgot to say hi. And it just kind of, the jaw hit the floor. And I think the message was, don't dismiss patients. Don't dismiss anybody.
I think that's
So,
really good advice. But
and
yeah, I
that's
mean,
because I have a particular access, and unfortunately, I'm not able to blend into the background.
like,
I may not pull the fire alarm this time, but I might. So.
again, if anyone else has any questions, please let us know. So Jeff, what are some of the things that you're working on in the future? I guess as far as the IRB, like how long can you serve in that role? Do you have to?
It's kind of indefinite. I committed to a couple of years, and I've passed that, but I'm still very interested in it. I appreciate it. I understand it. And it's just, it takes me longer and longer to do reviews because I do more and more research, the more I learn. Whether it's looking up the geography of a country or diseases or just different things to learn. It's still very fascinating, very interesting to me. And I have developed a comfortable place. They know when they send a review to me, I will do what I do. I generally provide secondary reviews. The primary reviewer will go through the protocol and all the mechanics of it. I always start with the consent document. And for me, the process that I use is most of the consent documents are written in Word. So I do the read aloud. I have it read to me and I read along with it. That way I can see, I can feel what I'm hearing, and allows me to pick up things. Now, something that keeps me aware or awake during that is when they mispronounce things or do things, they'll they'll interpret things that I know what it means, but the voice, and I generally do it at a 1.5 speed, so it doesn't quite drag on. And then it allows me to underline and highlight and go back and look at that and make comments. And then I combine all those comments into my own document so I can write my comments together. At the end of it, I'll do with Word, you can do a reading scale. You can get a Fleshkigate reading score, but that's not always accurate. And there was one document, there was a reading level of 11th grade, which was acceptable. But there was one paragraph that was at 19th grade level, which is postdoctorate. It was copied from the protocol, and it really actually didn't need to be there. It didn't serve a purpose. But the old idea of throw everything in it rather than make it make sense, just removing that. And I can defer it until a change is made. And one of the things that has been welcoming is anytime I have a question about what something means, it's automatically deferred. If it does not make sense to the non-scientist, it's not right. If I have a question about what's this procedure, or a technical question, others will explain it. But if it's comprehension that I'm not gathering what the consent means, then that's automatically a deferral. It does not make sense. It doesn't have to meet a reading score. It has to meet the person's score.
So that demonstrates that what you say has teeth.
Yes.
Thank you.
Yeah, that non-scientist is an important role in the IRB. And, I think there's been some calls to even expand that to, I think the requirement is one non-scientist that can also be, but they're thinking maybe they might have another one, that there's some mandates to change the composition of, or expand the composition of non-scientists on IRBs. Everyone's coming back. I hopefully you had a good discussion. I think everyone's come back. So Jeff, Marianne, Julie, if you have anything you'd like to share from your rooms, any important themes you kind of want to wrap everything up in a bow for us, we have a little bit of time left.
Sure, I'll jump in. So just as a consumer, as a patient, remember that you have rights. You also have the power to make change. You can ask for easier to read materials. You can ask your pharmacist why they don't have easier to read prescription labels, because they're out there. And there are good publications that you can use to help make yourself, a more informed consumer. And for those of you working in healthcare, learn how to evaluate the reading materials that you're giving out, and make sure your materials are easy to read and that they're customized to your audience. You might want to try them out with your audience, have a group, because what you might give to one group may not actually resonate in another community or with another group. Let's see. I pointed out, just for those who weren't in my breakout rooms, that there are some tools like clinical trials and older adults. So that is something, a tool that is available on our library's health literacy resources subject guide, and I'd be glad to connect you to that as well. If you have suggestions or questions, please don't hesitate to contact me. Thank you.
So in our breakout room, we talked a lot about the use of informed consent templates to help reduce the redundancy of the information that is included in a document, particularly when you have, additional agencies that have requirements, and there's no need to state the information twice. Once is enough. But utilizing a template to get that information with clear sets of instructions for the research community so they understand. Talked some about data and how institutions gather data from communities, whether it's from their own data collected, if you're within a healthcare system, and how you couple that with other types of agency data. But emphasizing that, you know, the institution's ranking of what they might deem to be important in terms of, you know, here's the top risks or the top diseases or the top social issues in an area may not be congruent with what the community sees as what they need or require or want in terms of the anchor institution bringing in research activities. And that we also discussed about engaging with the community for better access, better treatments, and then bringing back that information to the institution. We talked about external IRBs, their strengths, their weaknesses, areas of improvement. And then we ended with some information on biobanking.
Jeff, if you want to close us out.
And one of the things that I've told people is that my secret is that I am never going to ask you to explain something. I'm going to say no. So I better understand it the first time you talk to me.
Powerful statement right there.
And that's why when you're asking the question, you should never ask a question that's a yes or no answer.
Yes.
So that you don't put Jeff in that position to say no.
I think my wife learned from you.
Well, I want to thank all of you for attending today. I want to thank our esteemed panelists for sharing their knowledge. Really appreciate everyone's time today. I put a file in the chat that has those resources. I'll send that to the people that signed up for this seminar, this roundtable, so you can have those resources, and the recording of this session will be available in a few weeks. But again, I'd like to thank Jeff, Marianne, and Julie for their time. I'd like to thank all of you for attending.